the chronic otitis media, the overview, what are the types, and the safe type of chronic otitis media that we covered, right? What are the other names of safe type of chronic otitis media? What are the other names? No, Atticoantral is unsafe. See, this classification safe and unsafe is no more it's used, okay. But if you get an old examiner and some of your textbooks, it's mentioned as safe type and unsafe type, Tubotympanic, Atticoantral, all these classifications, right? So Tubotympanic type or the mucosal type is the safe type. That is traditionally it's described as safe type, but not no ear disease, not any type of ear disease can be. It's not that it necessarily it can be safe always. Okay, it can have its own complications. So nothing is safe, and everything can be unsafe in long run. So we have covered all these things. Can you remember? Yeah. So now we will cover this thing, Cholesteatoma. So Atticoantral type is also known as Squamosal type of chronic otitis media. Now, in my last class I have told that this thing can be very dangerous at times, right? In terms of complications, it can have some complications. How to differentiate clinically between this thing, Atticoantral and Tubotympanic? The symptoms will be different. What different? So সব কিছু আমি তো পেছনে বলতে পারবো না, so I cannot proceed. Okay, so more or less Cholesteatoma, they present with some foul smelling discharge and it's scanty in amount, right? And it can present with the complications of Cholesteatoma. The hearing loss can be more, and what? Anything? It can present with sometimes with bleeding. Okay. Okay. So Cholesteatoma, you know the term oma means. Oma kokhon hoy? We use this term suffix oma when you describe a tumor, right? So Cholesteatoma is not a tumor; it's a misnomer. This terminology is basically a misnomer. Okay, so this term has been first used by Johannes Muller in 1858, and it's basically defined as a sac lined by matrix of keratinized stratified squamous epithelium which rests on a thin layer of fibrous tissue. ঠিক আছে? So we are talking about the pathology of the disease. What does it contain? It contains the desquamated keratin debris. সহজ ভাষায় বলতে গেলে where there should not be skin in ear, if you get the skin, that is Cholesteatoma. Okay, skin in a wrong place in a wrong way is basically Cholesteatoma. Okay, and that skin contains epithelium, desquamated keratin debris, they will be there, and it has some destructive properties. That's the basic thing. Okay, so it's not a tumor, it has nothing to do with anything with cholesterol, right? So the better terminology can be epidermosis. And Squamosal chronic otitis media is the type of, it's the other name of Cholesteatoma, right? So how does it be described? See, this is the matrix, this is the fibrous stroma, we call it perimatrix, right? This is the keratin mass. Okay, this matrix is basically stratified squamous epithelium, and this fibrous stroma perimatrix, it has a distinct characteristic, we'll talk about it later, and this is the bone. Okay, because of some complex pathology that is not required in your undergraduate thing curriculum, this whole thing started destroying these bones, right? So last class I have told you have an idea about the middle ear anatomy, I think everybody knows. So, in my last class I have told that the boundaries of the middle ear, it can erode all the boundaries and goes beyond the boundaries, okay. Of which the most important, the most complex one is it can go into the brain. It can have some complications. We will talk about that later. But have an idea that we are basically studying a disease which can have very dreaded complications. So, we cannot miss this thing. In our day-to-day practice, we cannot miss cholesteatoma. If we miss it, we are basically giving the patient an opportunity to get admitted in ICU on later date and possible death also, okay, sometimes. So, how the bone is destroyed? It can, one of the reasons is hyperemic decalcification, osteoclastic bone reabsorption because of these things, pressure necrosis. Initially it was thought that there is some role of pressure necrosis, but nowadays it has been proved that there is no role of pressure necrosis and nothing to do with the secondary infections. So, bone destruction property is basically of these things, of which this osteoclastic bone resorption is the main thing. Okay, there are many things that is being secreted from this perimatrix and matrix that causes this bone destruction. Okay, what are the types of cholesteatoma? One of the types is congenital, okay. Another is primary acquired, that is the cholesteatoma, okay. The cholesteatoma, what we see in most of the cases in our practice, that is the primary acquired, and secondary acquired, tertiary acquired, okay. We will talk about this later. What is congenital cholesteatoma? It has certain characteristics. It is described under Levin's criteria. This is the typical look. You will see there is no perforation, right. There is a whitish keratin mass like structure, whitish this thing pearl like structure behind the intact tympanic membrane, right. Can there be any discharge? There is no perforation in the tympanic membrane, right. These patients can straightforward present with some complications, okay. So, you cannot afford to miss this thing. If you see this thing in a child, it can be a case of congenital cholesteatoma, right. So, this can persist in the middle ear or in the middle ear cleft, even in the CP angle petrous apex area, right. Okay. So, if you get a patient with petrous apex cholesteatoma, it can have a typical symptom, bolbo, ঠিক আছে? But if you get a patient with congenital cholesteatoma in the petrous apex, it becomes very difficult thing because the surgery itself is very complex. So, we are talking about the theories for primary acquired cholesteatoma, okay. So, theory দিয়ে বেশি সময় নষ্ট করে লাভ নেই, but it has been mentioned in your book. The most important theory is this retraction pocket, okay. Because of the eustachian tube dysfunction, there are certain mucosal folds in the middle ear. It can have different pathways to maintain the middle ear pressure, okay. So, mostly in the posterior superior part or in the attic part where the negative pressure can be more detrimental. In those cases, this tympanic membrane can have this retraction type of pocket, okay, retraction in the middle ear, and that epithelium, it will start having this thing, keratin debris, and ultimately this pathology gets activated and the bone destruction started. It is one of the most important theory for having cholesteatoma. Another thing is basal cell hyperplasia. Hyperplasia of the basal cells in the epithelial layer of the tympanic membrane and their invasion into subepithelial tissues, okay. This is the primary squamous metaplasia. You know what is metaplasia? Barrett's esophagus, yeah. So, transformation of the middle ear mucosa into squamous epithelium, okay. It can be because of the repeated infection, it can be because of many other factors, okay. Now, it is the secondary squamous metaplasia. The existing perforation is there and the margin, you know, the tympanic membrane developed from ectoderm, mesoderm, endoderm, all the three layers we have. So, ectoderm, that is the outer epithelium, It transformed into the middle layer mucosa into squamous epithelium, right? When there is existing perforation, right? Now it is the epithelial migration of the epithelium via tympanic membrane perforation into the middle layer. Okay. So don't waste your time in all these things. You just remember the name and basic thing. Okay. And it is a post-traumatic cholesteatoma. Suppose there is a traumatic perforation of the tympanic membrane, and you instill the epithelium into the middle layer, right? শুনতে যতটা সহজ ততটা সহজ নয়, but to have an idea. Okay. So if you get a perforation if the perforation can be a marginal, or perforation can be in the attic. So if you get a perforation in the attic, be suspicious, very suspicious that this patient can have a cholesteatoma. If you are having a perforation in the marginal, you are having a marginal central perforation, this patient can have a cholesteatoma, right? পরীক্ষার সময় MBBS এর সময় ফাইনাল MBBS এ কেউ বলতে পারছে না what is marginal perforation, what is central perforation. Very unfortunate. মানে এগুলো তো বেসিক জিনিস, তাই না? How can we give marks? Anyway, so next thing is retraction pocket, again in the attic or in the posterior superior quadrant. Okay. Then cholesteatoma formation, then ossicle started destruction, getting destroyed. What is the most common ossicle that can be destroyed? Most common is incus, the lenticular process, the long process of the incus. That is the most commonly getting destroyed, right? Okay. Next, the middle layer mucosa can look very edematous, red. There can be epithelium ingrowth. Okay. Oral polyp can be there. Sometimes oral polyp, the cholesteatoma can present as an oral polyp. Okay. And ultimately there is extensive granulation and activation of the osteitis, and mastoid bone and all these things getting started destroyed. So that the destruction can proceed into the lateral semicircular canal. Lateral semicircular canal destruction hole ki hobe? Vertigo activated hobe. Fistula sign, right? If you get a fistula in our vestibular system anywhere, most commonly the lateral semicircular canal. If the destruction continues into the fallopian canal, I mean the facial canal, then facial nerve can be damaged, right? If the destruction proceeds towards the brain, that means the tegmen tympani or the tegmen mastoidium, the tegmen plate of the temporal bone. Okay, the destruction start holo okhane. What will have? What can happen? First thing, there can be an extradural abscess. Then the dura got breached. You can have a subdural abscess. Then it can proceed inside. You can have intracranial abscess. What are the common areas where you can have abscess? The temporal lobe of the brain and the cerebellum. Okay? And you can have meningitis as well, overall inflammation of the meninges, right? It can reach into the subarachnoid space. Okay. So these are the complications. Bolbo abar. So clinical features: ear discharge is scanty, purulent, continuous, foul smelling, blood stained. ভুল যেন না হয়, ঠিক আছে? If you get all these things, first thing is, am I dealing with a cholesteatoma? First impression in your mind should be, okay, you cannot afford to miss a cholesteatoma, right? Just like you cannot afford to miss a laryngeal cancer. You cannot afford to miss a malignancy anywhere. You cannot. Okay. So hearing loss can be mostly conductive type because the ossicular chains are getting destroyed, but it can be mixed type. Why? Cholesteatoma te sensory neural hearing loss o hote pare. Why? How? When it reaches the inner ear, by various mechanisms, সেটা নিয়েও পড়াশোনা হবে, ঠিক আছে? কিভাবে inner ear can be destroyed, the cochlea and I mean this, we have these things, okay, inner ear, and the patient can have A perforation, তাই তো? Where should be the perforation? Mostly in the attic, or it can be in the margin of the tympanic membrane, right? So marginal perforation কাকে বলে? Where the perforation annulus fibrosus কে involved করে, okay? Okay, very good. And you can see frank cholesteatoma flex. Cholesteatoma typical যে look, সেটা তুমি frankly দেখতে পেতে পারো, okay? Then it is also a case of, it's very easy to diagnose then, okay? And it can present as simple oral polyp. একটা পলিপের মতো দেখতে একটা জিনিস নিয়ে প্রেজেন্ট করলো. There is osteitis, granulation tissue, severe pain, all these things can happen, right? Typical look, this is the oral polyp, right? Spelling ta bhul ache anyway. And the typical discharge, right? See this picture, this is cholesteatoma. This is the tympanic membrane overall, right? Okay, this is the malleus, okay? This is the lateral process of the malleus. This is the pars tensa, right? Overall pars tensa ta bhetor dike ঢুকে রয়েছে, okay? So that is basically retracted tympanic membrane. There is a small perforation here also, right? But the area of focus is this area. Can you see? There should be a pars flaccida. We call it the attic or the epitympanum part of the middle ear, right? This is the head of the malleus, right? You can see it has been destroyed. There is frank cholesteatoma, right? Okay. That is the posterior superior quadrant cholesteatoma, right? So this attic part is not that much involved, but the posterior superior part of the tympanic membrane is involved. Okay. So how to differentiate? পরীক্ষায় 1000 বার জিজ্ঞেস করবে, এটা যেন ভুল না হয়. The tubotympanic or the safe type or the mucosal type, the discharge is profuse. In atticoantral type, the discharge is scanty. Tubotympanic, the discharge is intermittent. বেশিরভাগ টাইম ঠিক হয়ে যায়, okay? Drop of hanathana, oral toileting, give time, antibiotics, it gets resolved. There is no discharge for months, can be years. Then again it comes. But the atticoantral discharge will not get resolved, okay? It's continuous. It's mostly mucoid discharge in tubotympanic. In atticoantral, mostly purulent discharge. It can be blood stain, it can be foul smelling. You cannot have these things in tubotympanic disease. The atticoantral, the perforation is in attic or in the posterior superior margin. It can be anteriorly sometimes, but mostly in attic and the marginal perforation. Tubotympanic, it is the central perforation. Cholesteatoma, granulation, all this extensive you can have, you can see, but here it is not there. Another thing is tuberculous otitis media, okay? পাওয়া যায় না আজকালকার যুগে, but again sometimes you can see. আর তো তুমি যদি না জানো, what the mind doesn't know, the eyes cannot see. As simple as that. So it's a painless, odorless otorrhea refractory to regular antibiotics. বারবার অ্যান্টিবায়োটিক দিচ্ছ, কমছে না, এদিকে কোলেস্টেটমার আর কোনো ফিচার নেই, okay? You look the tympanic membrane, there can be multiple tympanic membrane perforations, okay? The middle ear mucosa is extremely pale, that is the catch, okay? Multiple perforation, ear discharge not resolving with regular antibiotics, and pale middle ear mucosa, these are all suggestive of tuberculous otitis media, okay? Yes, there can be early facial palsy, there can be early labyrinthitis, that means complications are early, just like pulmonary TB, okay? Okay. It looks like this. You can see multiple perforations. The middle ear mucosa through the perforation, it's pale looking and the discharge is not resolving, okay? So you have to give anti-tubercular drugs. So middle ear carcinoma, important thing is otalgia and blood mixed discharge, okay? Patient এসছে severe pain, okay? বোঝা যাচ্ছে না, মানে আমাদের ক্লিনিক্যাল ফাইন্ডিং এর সাথে মিলছে না, এত পেন, okay? And the patient is having blood mixed discharge. Middle aged patient, mostly male, and you can see in the CT scan there is extensive destruction, যে destructionটা cholesteatomar সাথে মিলছে না, okay? So you have to suspect middle ear carcinoma, mostly squamous cell carcinoma. How to diagnose? How to diagnose a carcinoma? First thing is no tumor marker. আমরা গরিব দেশে বাস করি। Tumor markers are mostly for research purposes in our country. Okay. Histopathological diagnosis is the key. It's the gold standard for any carcinoma. Whenever you can get any carcinoma, anything for solid tumor, okay, the histopathological diagnosis is the key. কখনো কখনো করা যায় না because of the abnormal locations, all these things. Then you have to rely on the imagings and other things. Okay, nuclear imaging or the regular imaging, CT scan, MRI, PET CT, whatever it is. Okay, but here you can get a tissue, right? Under microscope you can have a biopsy, and that biopsy can give the diagnosis. How to investigate? এই কোশ্চেনটা পরীক্ষায় 100% স্টুডেন্টকে জিজ্ঞেস করা হবে। Whatever case of ear you can get, the examiner will ask how to investigate this patient. Okay, and investigation এর মধ্যে আজে বাজে কথা বলা শুরু হয়, এগুলো বললে হবে না। Okay, first thing is you have to examine under microscope. ঠিক আছে? Why? আমরা তো এমনি সিম্পল রেগুলার ওটোস্কোপ দিয়ে বা এন্ডোস্কোপ দিয়ে দেখতে পাচ্ছি, তাহলে মাইক্রোস্কোপের কি প্রয়োজন আছে? Why we are using microscope? To see a ear, to diagnose, for diagnostic purpose only. Because microscope can give you a 3-dimensional view. Okay, you can get a good idea about the depth, what can be the middle ear volume, what is the exact look 3-dimensionally. Endoscope cannot give you a 3-dimensional view. একটা টিভিতে দেখা হচ্ছে, তাই তো, একটা 3-dimensional স্ট্রাকচারকে 2-dimensionally আমি দেখছি, বাট মাইক্রোস্কোপ ক্যান গিভ ইউ আ 3-dimensional ভিউ। ওকে, সেকেন্ড ইজ the discharge has to be cultured. Okay, we'll have a culture sensitivity, we'll have specific audiological test, that is pure tone audiometry. Patch test is not required and you will go for an imaging, right? So imaging, X-ray mastoid আগেকার যুগে করা হতো, পরীক্ষায় তোমাদের জিজ্ঞেস করা হবে, that's why I have written X-ray mastoid, but nowadays it has been grossly replaced with CT scan, right? And X-ray mastoid এর মধ্যে ভিউটা কেউ বলতে পারে না, কেউ বলতে পারছে না, it's the lateral oblique view, right? Why lateral oblique? কারণ আমাদের দুটো কান আছে তো, তাই তো, তুই যদি সিম্পল ল্যাটারাল ভিউ নিস তাহলে একটার সাথে তার একটা সুপার ইম্পোজড হবে, কিন্তু বুঝতেই পারবি না। দ্যাটস ওয়াই উই আর হ্যাভিং ল্যাটারাল অবলিক ভিউ, রাইট? এটা জিজ্ঞেস করা হবে পরীক্ষায়। অডিওমেট্রির মধ্যে, অডিওমেট্রি, হোয়াট ইজ দ্য ইম্পর্টেন্স অফ অডিওমেট্রি, কথাগুলো বলতে হবে। হোয়াট টাইপ অফ হিয়ারিং লস আদৌ আছে কিনা, তাই তো, হোয়াট ইজ দ্য ডিগ্রি আর সিভিয়ারিটি অফ দ্য হিয়ারিং লস, হোয়াট ইজ দ্য স্ট্যাটাস অফ দ্য হিয়ারিং অফ ইন আদার ইয়ার. It is for a recording purpose. Post-operatively, so you have to compare with your results, and it's for the medical legal purpose also. Okay. Patient এসে বললেই তো হলো না, স্যার আমি কানে কম শুনি, আমার একটা হ্যান্ডিক্যাপ সার্টিফিকেট দিয়ে দিন। You have to have some proof, তাই তো? Okay. So patch test এর দরকার নেই, ছেড়ে দাও। হ্যাঁ। So Atticoantral type কি same জিনিস, but more focus on CT scan, right? When you are suspecting a case of cholesteatoma, you will go for a CT scan. Okay? But in tubotympanic, most of the cases, CT scan is not required, X-ray is enough. Okay? Okay. But nowadays, as the medical legal cases are rising, it's safe to have CT scan in all cases, right? Okay. So X-ray mastoid, there are 3 types of pneumatization in the mastoid ear cells. There are different kind of ear cells, right? It depends upon the location. What is the most consistent ear cell of the mastoid? You call it mastoid antrum. Okay, it's the largest and most consistent. So if you have a plenty of ear cells, it's cellular mastoid. If you have a small antrum and air cells are very less, it is a sclerotic mastoid, very bad mastoid I think for surgery. And if you have a bone marrow within few air cells, it is a diploidic air cell, okay, mastoid. So in cholesteatoma, you will have a cottonwool appearance. You will see a cavity inside the, the X-ray, okay, in the mastoid area, which doesn't have a smooth margin. Okay, smooth margin jodi hoy tahole it's mostly a post operative defect. Amra operation er shomoy bone ta remove korechi. Okay, if it doesn't have a smooth appearance, it's having a cottonwool appearance, then mostly it's a cholesteatoma. Okay, so bone destruction, it can be present. What is the extent of the bone destruction, that we can have an idea. Okay, so পরীক্ষার সময় এটা দেওয়া হবে, রেডিওলজিতে আবার পড়ানো হবে তোমাদের যখন ক্লাস নেওয়া হবে. This is the dural plate, this is the sinus plate. What sinus? This is the limit of the mastoid. This is the dura mater, right? And this is sigmoid sinus, right? Okay, এগুলো পরীক্ষায় পড়ানো হবে. This is the external auditory canal, this is the temporomandibular joint, this is the cortic, the mastoid, okay, system. This is the cellular type, you can see lots of cells. This is the sclerotic type, you can see there is no cell, right? The পুরোটাই সাদা হয়ে গেছে, and this is the diploidic type. You can see there is a defect in the attic, okay, in cholesteatoma, that is the attic erosion. You can see the big cavity here, right? Lots of destruction, that is also cholesteatoma. And this is the CT scan, okay. So CT scan alada kore class nebo ami. You can see the destruction, level of destruction, okay. These are all destroyed, these mastoid air cells are destroyed here, everywhere, okay. And posterior canal wall is also eroded, and mostly the patient comes with a fistula, okay. This is also the mastoid cholesteatoma. Now coming into the treatment, okay. How do you treat it? In both the cases, we will treat with surgery, as simple as that. But surgery korar age you have to prepare the ear, okay. You cannot operate on an infected ear. Grossly infected ear e tumi operation korte paro na. So in tubotympanic variety, suppose the patient coming with lots of discharge first visit, you cannot ask him to get operated on the very next day. It's not possible. So you have to first give an oral toilet, right? You will give a good suction. You will suck out all the pus and mucoid discharge with the use of this thing ear wick. You will just get a good dressing. Okay, you will give antibiotics, systemic, cortical, topical, other things, nasal decongestant. Okay, all these things. Then the ear becomes dry. There is a perforation, but it's a dry perforation. Okay. Okay, you will ask the patient to avoid swimming pool activities. During bathing, there should be a earplug should be used, or at least Vaseline soaked cotton should be used, right? Air should not get any entry. No oil, no self cleaning, all these things, okay? So after oral toileting, all these things, you will go for a surgery, right? When you will go for a surgery, if the infection gets absolutely dried, it's an inactive disease, then you can go for a Tympanoplasty or Myringoplasty. Bolbo shob, what is Myringoplasty, what is Tympanoplasty? Myringoplasty is basically reconstruction of the damaged tympanic membrane. Okay, Myringo means anything with tympanic membrane, no, tympanic membrane, and tympano means anything with tympanic membrane or middle ear, okay. So এগুলো controversial কথাবার্তা, what should be done, it's a matter of debate, but mostly we will go for a tympanoplasty or tympanomastoid surgery, okay. Whatever is needed, that decision depends upon many things, okay. সেটার জন্য পোস্ট গ্রাজুয়েশন লেভেলে পড়াশোনা, but mostly we will get a surgery of the tympanic membrane. It can be Myringoplasty, it can be Tympanoplasty, or it can be tympanomastoid surgery. But if the disease, there is a lots of disease in the mastoid, then we will go for a mastoidectomy. Okay? Okay. Don't go with this. So myringoplasty is reconstruction of the tympanic membrane, right? So what are the indications? Suppose you are getting a job. First of all, you have to get a good dry ear with good hearing. That is the আমরা আমাদের অরিজিৎ সিং এর গানই যদি শুনতে না পেলাম, what is the মানে meaning of life, right? So you should have a good hearing. That is the aim of our surgery. You can get a dry, safe ear and good hearing, right? Okay. So for that we have to reconstruct the damaged tympanic membrane. We have to reconstruct the damaged ossicles, right? Okay. And you have to, with this surgery we can prevent some complications, future complications. What are the complications? The future tympanosclerosis, adhesions, vertigo, all these things. Okay. Suppose you are prescribing a patient a hearing aid for a sensory neural hearing loss. Okay. The patient এর একটা perforation আছে, ঠিক আছে? তো still you are offering the patient a tympanoplasty surgery. Tympanoplasty করে কি ওর sensory neural hearing loss ঠিক হবে? হবে? হবে না তো? পেশেন্ট এসছে, আমি শুনতে পাই না ডাক্তারবাবু, আমার একটা ব্যবস্থা করে দিন শোনার, তাই তো? সো তাও আমি tympanoplasty কেন করব? So that we can have a dry ear and there is a tympanic membrane to get a good results with hearing aid, তাই তো? Tympanic membrane নেই এত hearing aid দিয়ে যে সাউন্ডের কোয়ালিটি, that can be very inferior in terms of when there is a good active intact tympanic membrane. Suppose the patient is an occupation like a military this thing, BSF এর চাকরি নিতে যাবে, পুলিশের চাকরি নিতে যাবে, pilot, you have to have an intact tympanic membrane. Okay? And patient is a professional swimmer, scuba diving করতে ভালোবাসে, ঠিক আছে? পেশেন্টের যদি tympanic membrane perforation থাকে, ও তো রোজই হাসপাতালে আসতে হবে ওকে। So in that case you have to have this thing. What are the contraindications? For a simple myringoplasty, simple myringoplasty contraindication কি? যখন ডিজিজ tympanic membrane এর বাইরেও রয়েছে, mastoid-এর মধ্যে extensive disease আছে, then you have to have another surgery. Myringoplasty is not enough. Okay? If the patient is having otitis externa, so infected জায়গা we will not do. Okay? We will try to treat the infection first. Severe allergy respiratory, you have to treat the allergy first. Okay? Age less than 7 years, it's a debatable thing. Some people says that okay, less than 7 years is also okay. Some people prefers between above 12 years of age for this surgery. It's debatable thing, it depends upon the surgeon itself. Okay, the only hearing ear, একটা কান পুরোই গেছে কালা, so you are giving the patient, you can give a patient a complete dead ear in other ear. Okay, so in those cases if possible you have to avoid any ear surgery. Okay, so what are the methods? Methods নিয়ে অনেক আলোচনা হবে পরের দিন. There are basically two techniques, underlay, overlay. Overlay technique basically completely obsolete right now. We always do underlay technique. We use different types of grafts. The most commonly used grafts is temporalis fascia, right? You know the muscle temporalis? Temporalis এর উপর একটা fascia থাকে, তাই তো? That fascia is best graft material for reconstruction of the tympanic membrane. Why? Why? Common sense. First of all, এই কানের কাছেই তো এখানে থাকে, তাই তো? You just extend the incision, you can get the fascia. আলাদা কোথাও শরীর থেকে বার করতে হবে না. Okay? Next thing, its characteristic should be similar to tympanic membrane, তাই তো? তাই তো? It's just strength, tensile strength, everything, it's very similar to tympanic membrane. And the most important thing is, it has a very low BMR. What do you mean by BMR? মানে কম খেয়ে বেঁচে থাকতে পারে. It's a free graft. এটার কোনো আলাদা করে ব্লাড সাপ্লাই নিয়ে কোনো মাইক্রোভাস্কুলার অ্যানাস্টোমোসিস করা হয় না. It's a free graft. তাহলে সে যদি একদিনেই মরে যায় তার ভাস্কুলারিটি পাওয়ার আগে, তাহলে তো অপারেশন তো সাকসেসফুল হবে না, ইট ইজ আ ফেলিওর, তাই তো? So that low BMR gives the material a chance to survive for months, right? In this period, in between, new vascularization happens. Okay, ultimately that graft gets resolved and new tympanic membrane grows, right? What are the other materials? এটাও পরীক্ষার সময় কেউ বলতে পারছে না। Perichondrium can be used, cartilage can be used, vein graft, fascia graft. But most commonly temporalis fascia and cartilage is extensively used, right? So what is underlay technique? See, this is the margins. So this is the tympanic membrane, this is a perforation, right? So epithelium grow kore giye, mucosa grow kore giye, this margin gets closed, right? The operation, what is the principle of the operation? We will first just we will make these margins raw, তাই তো? আমরা জাস্ট মার্জিনটাকে কেটে এই আগে এই লেয়ারটাকে সরাতে হবে, রাইট? দেন উইল এলিভেট দ্য টিম্পানিক মেমব্রেন, তাই তো? দেন টিম্পানিক মেমব্রেনের নিচে উইল প্লেস দিস গ্রাফট, ওকে, and this will heal. This is the vector, okay? The tympanic membrane will heal in this direction, both direction, not in this direction, right? So that is the principle, okay? So we'll place, this is the underlay technique, that is the most commonly used technique. Overlay technique is just the opposite. বলতে পারো পরীক্ষার জন্য, but it does not, মানে এটা করা হয় না nowadays, okay? Okay. What are the types of cholesteatoma? এটা পরীক্ষা অনুসারে জিজ্ঞেস করা হয় 1 2 3 4 5 6, okay? One is যেটা আমি বললাম, টাইপ 1 টিম্পানোপ্লাস্টি is basically myringoplasty, okay? যখন আমরা ম্যালিয়াসের উপর গ্রাফটটাকে প্লেস করছি। টাইপ 2 যখন ম্যালিয়াস নেই, ধর ম্যালিয়াসের হ্যান্ডেল ইজ অ্যাবসেন্ট, দেন উই প্লেস দ্য গ্রাফট অন দ্য incus, myringo-incutopexy. Myringo means tympanic membrane, incutopexy. Type 3 is myringo-stapedopexy. Stapes এর সুপ্রাস্ট্রাকচারের উপরে আমি গ্রাফট প্লেস করছি, রাইট? Type 4 is we placing it over the cavum minor. Type 5 is we are getting a fenestration in the lateral semicircular canal and we place the graft there. And type 6 is sono-inversion, okay? When only foot plate remains and foot plate is mobile, we get a perforation in the foot plate and we place it over the oval window. That's it. So ossicular reconstruction has different techniques such as we call it the, what is the name of the surgery? It's named as Osteoclastic, ossicular reconstruction. So এখানে আমরা অনেক রকম টেকনিক ইউজ করি, অনেক প্রসেসেস আছে, কার্টিলেজ আছে, এটসেট্রা এটসেট্রা. It's a huge topic. But if there is osteoclasty, the question will be asked like this: suppose there is ossicular necrosis, what will you do? So you will say we will do osteoclasty, right? So next day we will go for mastoidectomy and we will talk about the complications of the cholesteatoma and how to manage those complications. First we will know how to manage the cholesteatoma, okay? Okay. So for today it's finished.